Assalamu alaikum everyone. The next topic of discussion is non-Hodgkin lymphoma. Non-Hodgkin lymphoma is the most common hematopoietic neoplasm and its incidence increases with the age. Peak incidence is in those with age greater than 50 years. High-grade lymphoma are most common in children and young adults like 20 to 40 years. Etiology, so there are different types of causes like chromosomal translocation, most common 14-18. Infections like EBV, HIV, HTLV, HCV, H. pylori associated with gastric lymphoma, for example, mild lymphoma, mucosa associated lymphoid tissue lymphoma, and diffuse large B cell lymphoma. Autoimmune diseases like Hashimoto rheumatoid, immune deficiency like congenital immunodeficiencies, AIDS, history of chemo and or immunosuppressive therapy, and environmental factors like aromatic hydrocarbons, for example, benzene and radiations. Then we have overview of the different types of lymphomas. So we have B cell lymphoma and T cell lymphoma. B cell lymphoma are about 85% of our non-Hodgkin lymphomas. In B cell we have low grade and high grade. In low grade we have follicular lymphoma, which is most common low grade lymphoma in adults. Slowly progressive and painless course with alternating pattern of lymphadenopathy and splenomegaly, and translocation is 14-18 translocation, which involve the heavy IgG present on chromosome 14 and BCL2 gene, which is present on chromosome 18. So overexpression of BCL2 occur in this case. So dysregulation of apoptosis normally inhibited by BCL2. Normally the BCL2 inhibit the apoptosis. Here the overexpression of BCL2 occurs, so apoptosis is inhibited here. So there will be finding of centrocytes, which are nodular small cell with cleaved nuclei. Now the second is hairy cell leukemia. It's most common in middle-aged men, and there is mature B cell tumor. BRAF mutations occur, which are oncogenes for the serine and threonine kinase. Clinical features, so there will be pancytopenia, mesospleenomegaly, but here are no lymphadenopathy and B symptoms are rare. Diagnostics, so usually tartrate resistant acid phosphatase stain positive, so TRAP stain positive. Flow cytometry preferred over TRAP stain, so there will be marker of CD11C, and on CBC we will have leukopenia is common, but of 20% patients have leukocytosis. Peripheral smear, there will be hairy cells. They have irregular cytoplasmic projection that cause the characteristic hairy appearance. Bone marrow aspirations often yield a dry tape due to bone marrow involvement with subsequent fibrosis. So these are some points about hairy cell leukemia. You will have no lymphadenopathy, B symptom are rare, and there will be pancytopenia, splenomegaly, and TRAP stain positive, CD11C marker, hairy cells, and there will be a dry tape due to marrow involvement with subsequent fibrosis. In the third type of low-grade lymphoma is marginal zone B cell lymphoma, which is a group of lymphoma that arise from post-germinal center B cells, most common in adult associated with autoimmune diseases types. So we have extranodal, nodal, and splenic. Extranodal, so gastric mild lymphoma is most common, and non-gastric mild lymphomas, for example, thyroid, salivary glands. Nodal are monocytoid B cell lymphoma and splenic. Then we have gastric is associated with translocation 11-18 and H. pylori infections. So we have extranodal, nodal, splenic, and we have gastric mild lymphoma, which is associated with translocation 11-18. Then we have Waldenstrom macroglobulinemia and IgM antibodies are elevated, and the last one is small lymphocytic lymphoma. Small sheer histologic feature with CLL. However, the neoplastic cells are primarily located in the lymphatic tissue. That's why it's called lymphoma rather than circulating in the blood. Now we have high-grade B cell lymphoma. So first is diffuse large B cell lymphoma, which is most common in adults, caused by mutation in BCL2, BCL6, and P53. We have a subtype is known as primary CNS lymphoma, which is associated with EBV and AIDS. There will be focal neurologic deficits and neuropsychiatric symptoms, and on MRI there will be ring enhancing lesions. Then the second type is mantle cell lymphoma, which is most common in adult men. Translocation involve 11-14 involving cyclin D1, which is present on chromosome 11, and IgG on chromosome 14. So there will be increased level of cyclin D1, which promote the transition of cell to the S phase. There will be CD5 positivity, and it spreads rapidly. Most patients are diagnosed with advanced stage 4. Then we have Burkitt lymphoma. So Burkitt lymphoma is most common in children, except HIV associated Burkitt lymphoma, which is most common in adult. Translocation, so there is 814 translocation in 75% of cases. Reciprocal translocation involving the CMYC gene, chromosome 8, and heavy chain Ig locus on chromosome 14. So overactivation of CMYC proto-oncogene, so activation of transcription. Forms we have sporadic, typically located in the blood, in the abdomen or pelvis. Second type is endemic, which is associated with EBV. Most prevalent in Africa and South America and is typically located in the maxillary and mandibular bone. Immunodeficiency is associated with, example, HIV infections. There will be starry sky pattern, microscopic finding there it resembles starry sky, and tangible body macrophages containing many phagocytous tumor cells are scattered diffusely within a sheet of uniform neoplastic cell lymphocytes. And bowel obstruction can occur due to abdominal mass. Then we have precursor B cell lymphoblastic lymphoma, most common in adolescent and young adults. Burkitt lymphoma is most common in kids. This is the image showing the Burkitt lymphoma, where the lesion has central ulceration and there are peripheral scalings and there is a swelling present in the mandible bone. Then we have these hairy cells which have hair-like cytoplasmic projections. So these are hairy cells. And there are enlarged nuclei with slightly irregular borders. So these have hair-like projection and irregular borders. So that's different types of B cell lymphoma. Now we should discuss T cell lymphoma, which are present in about 15% of the non-Hodgkin lymphomas. So in T cell lymphoma, first we have low grade. And low grade we have mycosis fungoides, which is most common form of cutaneous T cell lymphoma, a type of lymphoma characterized by malignant T cell infiltration of the skin. Only skin involvement is there, pruritic cutaneous plaques and patches that develop brownish nodules, and there will be portrait microabscesses. Then we have high grade. In high grade we have Sézary syndrome, which is leukemic form of cutaneous T cell lymphoma. It's leukemic form. Cutaneous involvement and development of true T cell leukemia result from progression of mycosis fungoides or arise as de novo disease. Peripheral smear will show CD4 CD positive T cells with profoundly grouped or cerebriform nuclei which look like brain, term as Sézary cells. So we have Sézary cells in Sézary syndrome. The second type is adult T cell lymphoma, occur almost exclusively in adults and caused by HTLV virus associated with IV drug use. Presentation, leukemic presentation is most common, and there will be hepatosplenomegaly, lymphadenopathy, variable morphology, cutaneous lesion, hypercalcemia, abdominal pain, nephrocalcinosis, bone pain, latex lesions. There will be psychosis, elevated LDH. And chronic presentation less common, mild lymphadenopathy and lymphocytosis. Then we have NK cell leukemia associated with EBV, and the common feature are fever, liver failure, DIC. Then we have angioimmunoblastic T cell lymphoma associated with EBV and is characterized by autoimmune hemolytic disorders. Then we have precursor T cell lymphoblastic lymphoma, predominantly adolescent and young adult. There will be shortness of breath and superior vena syndrome due to mediastinal mass. The neoplasm often begins in the thymus. Now this is the appearance of cutaneous T cell lymphoma. And this is the appearance of the mycosis fungoides, which are multiple, partially confluent, sharply demarcated erythematous scaling plaques. For hair cell leukemia, you can remember hair can get trapped in the hair dryer. So hair cell leukemia traps can positive and there will be dry tape. Clinical features, so we have nodal disease, typically painless lymphadenopathy associated with fatigue and weakness. Multiple non-contagious lymph node may be involved. High grade, low grade. And high grade, there will be rapidly growing mass nodes and there will be constitutional symptom or P symptoms like weight loss, fever, night sweat. Low grade, slow growing or undulent lymphadenopathy or months or year, hepatosplenomegaly and cytopenias. Patient may present with anemia, bleeding or have increased susceptibility to infection. This is the picture showing cervical lymphadenopathy. Features of the extranodal disease, so it depends on the affected tissue and the B symptoms are common. So GI tract, neurologic involvement, thyroid involvement, and primary cutaneous non-Hodgkin lymphoma or secondary skin infiltration. They can also present as oncologic emergencies. Differential diagnosis, so we have 4 T's of the anterior mediastinal mass: thymoma, teratoma, thyroid neoplasm, and terrible lymphoma. Necrotizing lymphadenitis is another differential diagnosis. It is also known as Fujimoto disease. Etiology unknown. Epidemiology, so it's rare, most commonly in Asian population. Mean age is 30 years. Clinical features, there will be painful cervical lymphadenopathy and fever. So there will be painful lymphadenopathy. Diagnostic lymph node biopsy shows single or multiple necrotic foci and has histocytic cellular infiltration without granulocytic involvement. Treatment resolves spontaneously within 1 to 4 months of onset without treatment. To confirm diagnosis and determine the subtype of lymph node biopsy and or tissue biopsy. Imaging can be used to determine the extent of the disease and detect possible CNS involvement, and bone marrow aspiration and biopsy to detect marrow involvement. Lab findings, so in lab we will have CBC will show signs of anemia, thrombocytopenia, and WBC may be high or low. Commonly leukopenia occur, lymphocytosis can also present. Serum calcium may show hypercalcemia due to increased 1-alpha hydroxylase level. LDH usually elevated and beta 2 may be elevated. Viral serologies can also be done. Confirmatory diagnosis tests or pathological studies are required to diagnose lymphoma. Selection of the biopsy samples and nodal disease, most appropriate lymph node for the biopsy. Selected techniques are preferred techniques are excisional lymph node biopsy or core needle biopsy, alternative incisional, and avoid fine needle aspiration. Extranodal excisional tissue biopsy are recommended. Histopathology and specialized studies. So we have histopathology and immunophenotype. On immunophenotype, we look for the different markers like B cells lymphoma will be positive for CD20 while T cell will be positive for CD3. CD20 positive lymphoma will get benefit from the rituximab, which is a target therapy for it. Staging and classification. Now in staging we have imaging, so imaging depend upon the subtypes. Like those who are metabolically active, they take glucose. So PET-CT is used, while those where glucose uptake is reduced. So these are non-FDG fluorodeoxyglucose NHL. So we do CT with contrast. Bone marrow aspiration is done, and assessment of the CNS involvement we do imaging like MRI or CT and lumbar puncture with CSF assessment. In classification, so Lugano classification is the preferred in which imaging and bone marrow biopsy is used to classify. The disease is then classified either limited disease stage 1 plus 2 or advanced disease stage 3 plus 4. Stage 1 there will be one node or one group of node, while in stage 2 there will be two or more nodes are greater or equal to two groups of node on one side of the diaphragm. In advanced disease stage 3-4, node on the both sides of the diaphragm or supradiaphragmatic node with splenic involvement. This will be stage 3, or diffuse or disseminated disease, so will be stage 4. Treatment approach, so for low grade we consider radio as a curative intent, while for the high grade chemo usually with curative intent, while low grade the advanced stage usually palliative chemo is given. Selected patient may benefit from splenectomy and hematopoietic stem cell transplantations. Medical therapy, so we have radiotherapy and then we have chemotherapy. In Q we have antifolates, alkylating agents, topoisomerase 2 inhibitors, alkaloids, steroids, and immunotherapy. Intrathecal can be used like intrathecal methotrexate for leptomeningeal involvement. So R-CHOP is the most common regime used in NHL, in which R is the rituximab, which is used for the CD20 positive B cell neoplasms. For Burkitt lymphoma, so systemic aggressive chemotherapy with the non-cross resistant drug for a short period of time. For diffuse large B-cell lymphoma, systemic chemo with R-CHOP. It is combined with radiotherapy and CNS prophylaxis is given. Follicular lymphoma, so often no treatment is required. Mantle cell lymphoma, R-CHOP, cytarabine or bendamustine, rituximab. Here is leukemia with cladribine or pentostatin. Mild lymphoma, usually eradication of H. pylori, surgery or radiation. And for peripheral T-cell lymphoma, CHOP-based chemotherapy. Cutaneous T-cell lymphoma, so skin-directed therapy like phototherapy, topical chemo, topical steroid, and topical retinoids. Additional therapies, so hematopoietic stem cell transplantation and surgery like splenectomy can be considered in some. Prognosis, so typically the prognosis is worse than the Hodgkin lymphoma. Low-grade lymphoma median survival 6 to 10, while high-grade survival typically several months. Indicator of poor prognosis are old age, number of lymph node involved, which are nodal and extranodal sites, increased LDH and increased beta 2 microglobulin.